All right. Before we jump into this episode, I do want to set the stage a little bit. This conversation is between Dr. Lewis and Dr. Sigmon, a trauma surgeon with Mercy. And it's one of those that's easy to listen to, but if you're not careful, you'll miss just how big some of these points actually are. Because what they're talking about isn't just trauma care. They're talking about a shift in how we think about shock. For a long time, EMS, and honestly medicine in general, has been very numbers driven. Blood pressure drops, fix it. Heart rate goes up, fix it. Something looks abnormal, normalize it. But trauma doesn't work that way. In trauma, the body is compensating for a problem. And sometimes when we fix the numbers, we actually make the patient worse. So as you listen to this, I want you to keep a couple things in the back of your head. First, shock does not equal hypotension. If you wait for the blood pressure to drop, you're probably already behind. Second, not all hypotension needs to be corrected immediately. There are situations where letting the patient ride a little lower is actually protective. And third, there are exceptions to everything, especially when we start talking about head injuries. You're going to hear them touch on TXA timing, fluids, permissive hypotension, and when to be aggressive versus when to hold back. This is one of those conversations that should make you pause a little bit the next time you're in the back of the truck thinking, should I fix this, or is this the body doing exactly what it needs to do? All right, let's get into it.
All right, today we're with Dr. Sigmon, one of our trauma surgeons, and he's going to talk to us a little bit about trauma care and how we're taking care of patients in the pre-hospital setting. And specifically, we were kind of talking about, before we started this, is shock index. When people are shocky, their blood pressure's low, their heart rate's fast, what kind of things should we know about shock index so that we're taking care of our patients better?
Sure, and shock index is a great thing. It uses blood pressure and the heart rate, both of which can kind of be canaries in coal mines. There was the initial shock index, which was your heart rate over your blood pressure. So if you think about that, a normal person, heart rate of 60, blood pressure of 120, that's a shock index of 0.5. So you actually want a low score on this thing. And then, as I said, the initial shock index was with the systolic. So you can imagine if they now have a systolic of 100 and a shock and a heart rate of 100, they've gone to 1. That's where we start to get concerned. Between 0.5 to 1 is considered pretty normal, although being on the lower scale is better. Once you start getting on up to 1.3, 1.5, you start to get quite concerned. Some institutions will even say at 1.5 to 1.7, you can pre-activate MTP protocol. Unfortunately, there haven't been a lot of trials to that degree yet. It's very institution specific at this time. And then what started to supplant it is what's now called the modified shock index. So that's actually using MAP instead of systolic. Obviously, you have to bump it up a little bit. Normal becomes something in the 1.3 range. But the concept is still the same. It's your heart rate divided by your blood pressure, just MAP in this case. The higher your score, the more concerned you need to be. And certainly indices as high as 1.7, again, you want to call ahead and say, hey, we're concerned this patient may need massive transfusion protocol. Now, it's worth noting people that are electronically paced, people on beta blockers, people with bad heart failure, these are all things that can kind of obfuscate this. And kind of cloud that judgment. So keep in mind their clinical history. But certainly a young, healthy trauma patient just stabbed or shot in a bad car accident, it's a very, very valuable tool.
So really that could be a lot more sensitive for us using this modified shock index rather than the old school, the primary shock index. When my heart rate was higher than my systolic blood pressure, that I knew that number was bad and I need to address this. But some of those patients aren't going to fit that picture.
Sure,
right?
Yeah, and that's why a lot of people are migrating to the modified. I think realistically, it's pretty intuitive. You have a high heart rate, you have a low blood pressure. That's bad, and this is a way that kind of just standardizes your approach to it. I think most people have moved to the modified just because I think it seems intuitive to use a MAP rather than a systolic. And like you said, especially for those people, right-sided heart failure or something like that traditionally have a diastolic that's a little bit low, they don't get lost as having a relatively normal blood pressure.
All right. So, and particularly, so what are some of those patients that are going to fit? When I first think about it, I think about, a lot of those dialysis patients that kind of have those soft blood pressures anyway. A little bit of tachycardia gets them, or, I think this person needs blood, but if I use MAP, maybe that'll help me.
Yeah, hopefully, like I said, there's a reason why it hasn't become a huge thing yet, and people haven't done true randomized trials saying, okay, this is our new cutoff. I'm sure they're out there and in progress, but at an institutional level, it can be kind of a helpful thing. Again, this is probably most valuable in your younger, healthier trauma patients. Once people start getting sick, start having cardiac problems, start having blood pressure regulation problems secondary to their dialysis, then it gets a little bit trickier, certainly. Most valuable in your acute trauma patients.
Yeah, I think about those beta blocker patients.
Yeah, that right off the bat, that's a problem.
Always 60, right? It doesn't
Exactly, even when their blood pressure is 50.
Yeah. Okay. Well, that kind of leads us into talking about fluids and fluid resuscitation, because our Lifeline helicopters obviously carry blood. They can initiate blood for us. We can call them. But we're coming into the winter seasons here where we're not going to be able to fly all the time. So help us kind of understand which patients we should be operating or pushing fluids on, which ones we need to be a little conservative, because it's tough. I know we're supposed to have some permissive hypotension, but how much is too much, and when do we give them that liter of fluid to try to hold them over? Is there a time that we would ever want to give them push dose pressors, a little bit of epinephrine to bump that blood pressure to keep them up?
It's a great question, and it was actually, the giant in trauma surgery, Dr. Maddox, that came up with the idea of permissive hypotension. And people kind of live at this idea of like, you just don't want to get the MAP above 65. But realistically, I forget what he calls it. He calls it like the oppressiveness of empiricism or something. A number gets put in the chart, gets put in the literature, and everybody says, okay, that's our number. There have been no trials on this. Certainly there are reports from the military field of as long as the patient is mentating, you let it ride. And the idea behind this permissive hypotension is you don't want to dislodge any clots. So they finally clotted off that tear in their pelvic sacral plexus of veins. It's a very weak area. It can break down at any time. You're not doing them a whole lot of favors pumping up their MAP to 70, knocking that clot off and losing all that blood out of it. Right now, I think most people say 65 just because we have that idea of end organ perfusion. Also, the military is in a little bit different boat than the average patient out here in Springfield. Young, healthy guys with the walking blood bank readily available. Again, go back to that dialysis patient. They don't have as much room to tolerate that low blood pressure. But I think certainly in someone, massive blunt trauma, significant penetrating trauma, you're really worried about blood loss stuff. You don't want to go chasing a MAP. I think if the patient is mentating and the patient has a MAP of 65, you can pretty confidently say that you have acceptable end organ perfusion and you don't need to go chasing stuff. That pressor answer, again, people say, well, hey, shoot, give them pressors, great end organ perfusion, don't, increase the volume and potentially knock that clot off. I don't think we're quite there yet, especially in the civilian setting. I would always turn to fluids. I'm sure in these talks before, you've really covered the fact that we love blood more than anything else. You're not losing saline, you're not losing LR, whatever the new stuff is that's super balanced, the isotonic stuff, you're not losing that, you're losing blood. I think it's, I'm really excited to be here where we have great whole blood stuff going on. That's been a really cool thing about working here as a trauma surgeon. But I think when in doubt, give blood.
Absolutely. When we can get those helicopters in, we love in the fact that ours is carrying whole blood. That's a huge plus. So let me twist the screws just a little bit on you a little bit. And so tell me, that person that has less than a 65 MAP, but still mentating really well to me, am I going to push fluid on that person?
I think at this point I would still chase that 65. And it strikes me in the heart to say so, but we also live in a medical legal society. Heaven forbid they're just hanging on by a thread or there's a little bit artificially wrong in your reading. I don't think you'd be able to justify saying, well, I didn't give blood because I wanted to allow permissive hypotension.
How about for us that don't have blood? So I'm just going to dilute them out. So specifically for these listeners that are going to be on the ground ambulance, and if they can't get blood in, do I push fluid to thin them out on somebody that has a MAP less than 65, but yet still talking to me? I told you I was going to twist the screws on you, right?
We don't have access to any products. We don't have any access to FFP.
So some days we'll be able to fly them in, but there's definitely going to be days we can't get the blood to us, and we still have a 30 or 45-minute transport time to you, but they're awake and talking to me.
Sure. So I would add one thing is that if you don't have whole blood, resuscitation now for trauma has gone to FFP first. And the idea gets back to this permissive hypotension. And the idea is, well, if I pump you full of blood, get your blood pressure up, you're just going to leak it out. Whereas if I pump you full of FFP, maintain a relatively lower blood pressure, you can be closing that space off.
Yeah. And those are great for our helicopter service.
Yeah,
those
for the people that have
in our
it.
small
Yeah.
hospital. But again,
Sure,
our
if you're on the
ground trucks,
ambulance
these
and you
people
got to
that are
give
watching
fluids,
this,
if you've got to give it, you got to give it. I would be very, very judicious. Certainly pressors are not going to help in the setting of ongoing massive blood loss, and that's the big problem. You say, well, why don't give pressors? Well, that's probably not going to help. They're going to continue to lose volume. You're just going to clamp down that perfusion more. I mean, it may support certain things that are a little bit more robust, like your liver and your kidney, but you may end up with a bunch of dead bowel or something like that. I think if push comes to absolute shove that it's okay to give fluids, I would be very, very judicious. You are not, 75 is not better than 65 in this case. It's actually worse. So I would be doing just enough to get over it. But certainly the use of pressors in the setting of significant trauma is not recommended. So if you got to give fluids, you got to give fluids. But not just knocking that clot off, you're also diluting out whatever clotting factors they do have. You're diluting out their oxygen carrying capacity.
So maybe a 200 fluid bolus is better than giving them a whole liter at a time.
I think that's reasonable, yeah.
Just to get us just over the edge.
Just over the edge, yeah.
Okay.
That would be my thought.
All right, let me make it more difficult
Oh,
for
no.
you. Now we have a closed head injury patient and a trauma patient that we know those H-bombs. If I let them get hypotensive, if I let them get hypoxic, that they have much worse outcomes. Studies are really clear about that. So when or never should pressors be used on somebody with a head injury?
Sure, and this is in the setting of an isolated head injury, not a whole bunch of, in that case, that's a totally different ball game. So, at that point, they have all the clotting factors they need. They have everything, they're hopefully they're not anticoagulated. That's a whole separate can of worms. Yeah. But if we're not worried about massive blood loss, then I would say, first of all, it's definitely okay to give fluids, tank them up, because these people tend to be dehydrated anyhow, but also totally okay to put on pressors. If we're just trying to maintain brain perfusion, that's where it can be very, very helpful. And if the person's otherwise pretty healthy, then I'm not worried about the kidneys taking a little hit. I'm not worried about the bowel taking a little hit. They can handle that even if it takes 2 hours to get to the hospital, I think they'll be okay.
Well, that makes a super easy question for somebody with an isolated head injury.
Yeah.
But sometimes we don't get those. So now I've got multi-system trauma
with
a known head injury. They're altered, intubated by us. All we have is fluids and pressors on the way in. How do we ride that out?
Sure.
Are we still pushing for that 65? Are we pushing?
Great question. So that's the one where I would not ride the 65 quite so close. That's one where maybe 75 is better. At the end of the day, your kidneys can take a hit and you can get dialysis. Your bowel can infarct a portion. I can cut it out and sew it back together. At the end of the day, you got to preserve the brain. Otherwise, what are we talking about here? So that's another time where I would be more aggressive with my fluids. I would be more aggressive with my pressors. And it sucks that those patients have to be intubated. You lose that neuro exam. But certainly, brain over everything else. So you want to preserve that aggressively, be aggressive with that blood pressure maintenance.
Perfect. Well, that kind of helps clarify, at least from the expert's point of view, what we should be doing.
Sure, talk to the rest
outside.
of the department too.
Well, I appreciate you taking the time. Is there anything else from a shock index, fluids, blood, that you want to make sure that these guys and gals really understand?
Sure. I think we covered a lot of great ground today. I think one other thing we talked about before the show just for a minute was TXA. TXA is a great adjunct, breaks down or stops fibrinolysis, so it stops the breaking down process. It's funny that things have kind of gone back and forth, and we were talking about this beforehand. I remember when I was a resident, early data from the CRASH 2 was coming out. We actually stopped TXA for a good long while. We were in Chicago, but we were getting patients from rural Indiana. We were like, oh, if you can't give it within 60 minutes, then it's actually quite harmful. Latest data is showing that you have up to 3 hours to administer it. So I think, being aggressive with that TXA, and that may even help, if these patients we're just discussing, these complex polytrauma ones, if you can stop the bleeding, then you stop the blood pressure loss, then you can be a little bit more judicious with the fluids while trying to maintain that in-organ brain perfusion.
And for the most part, a lot of times we see these massive trauma patients in the first 3 hours. So TXA is the right route for us. And just to remind you guys, we are given the 2 grams of TXA for adults, so that it just makes it easier to get that whole infusion. But for some of those patients, we might see some people around that 3 hour mark or even further, particularly this time of year, people falling out of tree stands. They end up laying on the ground for hours before somebody finds them in a hunting accident or things like that. pretty clear
Yep.
over 3 hours.
Has been shown to be harmful
All right, so we want to stay away from TXA after that 3 hour
in
mark.
that setting. Absolutely. That's what the latest data shows anyway. Wait till the next crash trial and we might be singing a different song.
Perfect. Other things with TXA, obviously, it's given throughout Southwest Missouri, maybe not necessarily our service. It seems like I see people with TXA with just a laceration on their arm and a tourniquet on their arm. I see TXA with a cut on their scalp from an alcoholic that fell. You have some opinions about that?
Yeah, I mean, the data is back and forth on it. I think certainly it's been shown to have its greatest benefit within 1 hour, and then it starts to get more questionable. And I think the fact that there is some questionable data on long-term complications, particularly thromboembolic, if you don't have to use it, don't go crazy with it. But it has been shown, particularly in significant trauma, to have significant effects. And it decreases. So that first hour is golden. That's where you get your greatest mortality benefit. And then after that, it kind of decreases to the point where after 3 hours, it becomes harmful. But yeah, I would avoid, using it if possible in the setting of these very, very minor things. I mean, it's also just a waste of resources. Heaven forbid you give it to 3 people with, toe lacerations, and then you end up with a big pelvic fracture.
Well, and TXA is relatively cheap, and from our standpoint, we hear about the great things and the lives we're saving, but we never see any of the complications.
Sure.
I'm assuming you see enough TXA, you've seen a complication or two of?
I mean, it's super hard to tell because you're seeing these things in polytrauma. I mean, did this person have a fat embolus? Did they have a PE? They've been anticoagulated for years, and now we're holding their anticoagulation. I think that's why you see a lot of back and forth in this on the crash trials. It's very difficult to tease out, what exactly caused this pulmonary embolism. But certainly there's been enough statistical evidence after 3 hours that it's harmful to preclude its use in that setting.
Perfect. Well, that kind of helps let us understand a little bit better. We're probably not going to use it for the scalp laceration that we can put pressure on. If
Sure.
we've got a tourniquet on and we've stopped that bleeding, then it's not worth adding that risk for them, even under the 3 hours.
I think that's my opinion,
That's mine
but
too.
that's opinion at this point. We've kind of gone beyond the limits of these trials.
Yeah, perfect. Again, Dr. Sigmon with our trauma surgery, he will be the guy that will be seeing all of your successes and some of our failures when you roll in, and we appreciate you taking the time and talking to us.
Happy to be here. I want to thank you guys so much for everything you do for us. We know you're working hard, and you guys are working in that golden hour that makes the biggest difference in patients' lives. You can reach me at david.sigmon@mercy.net. Certainly if you have any questions about this episode or things you want to run by me. And thanks again, guys.
All right, so let's bring this back to what this actually means for us, because there's a lot packed into that conversation. But if we strip it down, there are really just a few things you need to walk away with. Number 1, stop chasing normal. Just because a number looks off doesn't mean it needs to be corrected immediately. In trauma, especially bleeding patients, that abnormal blood pressure may be the only thing preventing them from bleeding even more. Number 2, control the problem, not the symptom. If the patient is bleeding, fluids don't fix that. Fluids can temporarily improve numbers, but they don't stop hemorrhage. And in some cases, they can actually make it worse. Number 3, permissive hypotension is a tool, not a default. If your patient is still mentating, still perfusing, still maintaining some level of compensation, you don't have to rush to normalize their blood pressure. Be thoughtful, be deliberate. But, and this is the big one, number 4, head injuries change the game. The brain does not tolerate hypotension. So in those patients, your approach shifts. Now pressure matters, now perfusion matters more than bleeding risk. And then finally, timing matters. When they talked about TXA, that's one of those interventions where early makes a difference and late can actually cause harm. So this isn't about doing less, it's about doing the right thing at the right time. Because trauma care isn't about fixing vitals. It's about understanding why they're abnormal in the first place and knowing when to intervene and when to let physiology do its job. Because stable isn't always a yes or a no. Sometimes it's just Stablish.